Dr. Hawa and thank him for being the speaker of this. It's actually, to me, it's a very practical subject, but it's also a very difficult subject to teach. So thank you, Dr. Hawa. Without much further ado, inshallah, we'll get started.
Thank you. Thank you very much, Dr. Secretary. It's my pleasure to be here. And thank you for Planetary Health Academia for inviting me to deliver this mini course, if you like. We have this course, we run it over 2 days usually, but it's my task to squeeze it and make it concise, but at the same time, very practical, as Dr. Secretary was saying. The structure of the course will be, today we'll talk about basic hemodynamic physiology, the hemodynamic jigsaw puzzle, and here we will have a lot, if you like, of practical aspects, or we will address some of the challenges that we have in the ICU, and I will give you an overview, if you like, of the whole course and what we're going to be achieving by the end of this course. Tomorrow's session, we will cover shock syndromes, and then we'll dwell into the use of advanced hemodynamic assessment devices. And later on, we will have another 2 sessions in November, inshallah, where we will address the fluid responsiveness assessment question with its challenges. And then we will address the hemodynamic manipulators before we conclude with the perfusion indicators and truly case studies that would expect a huge interaction with the audience, inshallah. But you'd be rest assured, I'm not going to embarrass anyone in the first few lectures, but maybe towards the end of the lecture, after I've known you and you've known me, then we probably can interact more during the case studies. Now, without any delay, we'll start our, might be fair to say, a bit dry subject, however, it's quite essential. And I'll try to really focus on the practical aspect of the physiology related to the hemodynamics. So we'll talk a little bit about the venous return, then the cardiac output determinants. We'll do some physics, if you like, and the utilization of Ohm's law in hemodynamics, then the principle of blood pressure autoregulation, and what do we mean by perfusion and pressure when we say perfusion pressure, and how the heart and the lung interact, and how can we utilize this heart-lung interaction to develop some of the monitoring devices that we have. And I will end up with a few slides on the Glycocalyx and its importance in shock patients. And obviously, no one can do physiology or hemodynamics without mentioning the Fick equation. However, we will have more about it later on when we talk about the perfusion indicators. So we'll start with the venous return, and we know that cardiac output depends on venous return and cardiac function. So for the cardiac output to be achieved, we need an adequate venous return coming to the heart, and then this blood is ejected from the heart with adequate cardiac function. It's important to keep in mind that the input of the right ventricle, i.e. the venous return, should equal the left ventricular output. So whatever comes to the heart should end up leaving the heart. Imagine if there's any discrepancy, then there will be venous congestion, and you end up with pulmonary edema and all the consequences of heart failure. The cardiac output, we know, is directly proportional to the venous return. And again, we will address this when we talk about the ventricular-arterial coupling. We know in heart failure, high venous return causes the heart to overstretch, and that unfortunately leads to the congestion and all the features of heart failure. Now, this is a schematic representation of the venous return. People always think of the cardiac output as just the ejection of the blood. But imagine if this blood is ejected and didn't return back to the heart, then obviously you'll not have any blood to eject for the next heartbeat. The venous bed is the biggest blood capacitance in the body, and there you have the blood ejected into the systemic circulation, moved into the venous circulation, and then it will find its way back to the heart. So the central venous pressure determinants are quite related to the cardiac output and to the cardiac function and to the venous return function. We know that the cardiac function is reliant on preload, afterload, cardiac contractility, and heart rate. On the other hand, the venous return function is related to the vascular volume. And here some authors divide the vascular volume into stressed volume and unstressed volume. I'll explain this later on. And then also depends on the venous tone, the compliance of and the resistance in the venous bed. And finally, it depends also on the downstream venous pressure. So if the venous pressure is high, so there will be less venous return because there's impedance, if you like, or there's less of a gradient for the venous to return back to the heart. Magder quite nicely represented this in his this scheme, and here he reflected the return function or the venous return on the right side here, and you can see that when there's a gradient, the venous blood will return to the heart, to the right side of the heart, and then move on to the left side of the heart after moving to the pulmonary circulation, and then it will be ejected back to the systemic circulation all the way back to the venous side again. And here we have this the venous return famous graph, which was put initially by the famous physiologist Guyton. And here we have the Frank-Starling curve. We'll see if we intersect these two graphs, what we will get. Now, this is the initial graph that was illustrated or put forward by Dr. Guyton in his famous experiment on dogs and open-chested dogs. And basically, it's saying as the right arterial pressure reduces, this allows more venous to come back, but this will carry on until it reaches to a plateau here around -2 millimercury. Then this will go to infinity. So you didn't expect further drop in the venous diameter. Otherwise, this will lead to complete collapse of intrathoracic veins. We talked a little bit about the stressed and unstressed volume. And the idea of unstressed volume is the volume, if you like, in the middle of the blood vessel that's not exerting any pressure on the vascular walls, whilst the stressed the unstressed volume doesn't usually contribute to the mean systemic filling pressure. However, as soon as you reach to this stressed vascular volume, this will start impacting on the mean systemic filling pressure. And you can imagine it like a tank with two compartments. The blue-colored one is the unstressed volume, is the dormant volume sitting there, if you like, as a reserve. And then the mean systemic filling pressure is being exerted by the stressed volume. Now, we did talk about the Frank-Starling curve. Again, this is one of the major principles in hemodynamics. And we need to remember that the curve for the normal ventricle, the slope is quite steep compared to the flat curve for the failing ventricle, which means that your patient will reach to the flat portion of the curve earlier in heart failure than those with normal ventricle. Most of us would live on the steep portion of the Frank-Starling curve, and it's really important to keep this in mind whenever we are assessing patients for fluid responsiveness. Me and you, especially in the morning, we will be on the lower part of the Frank-Starling curve. That doesn't necessarily mean that we need to give fluid boluses or fluid resuscitation. We did talk about the if we superimpose the venous return curve with the Frank-Starling curve, and we can see in spontaneously breathing patients, so i.e. negative pressure ventilation, the Frank-Starling curve will start from the negative pressure side, and then the intersection point between the venous return and the ventricular contractility will give you the cardiac output. So what happens in the failing heart? You will have higher right arterial pressure or CVP, but at the same time you will have lower stroke volume hence lower cardiac output. What causes the central venous pressure to go up? There's many factors. Obviously, technical issues should always be kept in mind. However, in the experienced nurses, there shouldn't be an issue really. But we need to always remember this can go up in decreased cardiac function with normal or moderately elevated blood volume, or if you have high venous return because of expanded blood flow when you over-resuscitate your patient, then that might cause your CVP or your patient's CVP to go up. Or if there's decrease in the venous resistance without matching rise in cardiac function, as it happens in distributive shock patients with the septic cardiomyopathy. Now, moving on to Ohm's law, and we know that for a closed circuit, Ohm's stipulated that the dynamic system conduction depends on the difference between the inlet pressure and outlet pressure, and this will equal to the flow times resistance. And this triangle is easy to remember. That's why I kept it there. How is it correlated to the human body? Let's imagine the circulation is a closed circuit system, and then the difference in the pressure will be correlating with the flow and resistance. So if we swap the voltage with the pressure, the current with the flow, and the resistance will keep it as it is, then we will end up having the pressure equals the flow times resistance, and the flow would equal the pressure divided by resistance, and on the other side, resistance will equal the pressure divided by the flow. And to make it more correlating to the human body, let's replace the word flow with cardiac output. And here we have the cardiac output equals the pressure divided by resistance. You wonder why am I mentioning this at this stage? Because these are one of the, if you like, pillars of understanding the hypotensive patient. Now, based on what we can deduce from the Ohm's law, we can say that for systemic circulation, the mean arterial pressure minus the right arterial pressure, i.e. the CVP, would equal the cardiac output times the systemic vascular resistance. And or we can put the equation in the other way: cardiac output equals the difference of the delta pressure divided by systemic vascular resistance. Now, rewriting the equation, we want to deal with the map alone, then we will have the cardiac output times the systemic vascular resistance plus the CVP, or right atrial pressure. For the pulmonary circulation, we can apply the same principle as mentioned for the systemic circulation. Now, from this, we can reach to the conclusion that the determinants of the mean arterial pressure are the preload, the cardiac contractility, the afterload. These are the three which determines or are important for the stroke volume. We have the heart rate, and then we have the systemic vascular resistance. So whenever you are dealing with a hypotensive patient, ask yourself, where is the problem for this patient? Is the patient's problem in the stroke volume? And if you thought it's in the stroke volume, then you have to ask yourself, am I dealing with a problem with the preload? Am I dealing with a problem with the cardiac contractility? Or there's an issue with the afterload of the patient? Or is it simply there's a severe disturbance to the heart rate? So in complete heart block situations, you will have hypotension, or in malignant tachyarrhythmias, you will have also drop in the blood pressure. Or you can ask yourself simply, am I dealing with a problem with the systemic vascular resistance? And this, from the clinical examination, you can easily ascertain whether the problem is a systemic vascular resistance issue or not. We will elaborate more on this tomorrow, inshallah ta'ala, in the shock syndromes presentation. And then you think, is the central venous pressure contributing significantly to the issue? Usually it doesn't, but it would help if when you have a central venous pressure of of 1 or in -1, then probably your patient's quite dehydrated, and with this low blood pressure, you have to think of hypovolemia as a cause of the hypertension. Another way of putting it, that we know that the MAP depends on the cardiac output and the systemic vascular resistance. We know that the cardiac output depends on the heart rate, or the cardiac output is a product of the stroke volume times the heart rate. For the heart rate, we know that it gets affected negatively by the parasympathetic nervous system and positively by the sympathetic nervous system. On the other hand, the stroke volume is determined by the contractility of the heart, the preload, and the afterload. And then you can, if you like, further cascade down. The preload relies on filling time, and this is really important in patients with diastolic heart failure. And one of the, if you like, main principles of dealing with patients with diastolic heart failure is to slow the heart down to allow more time for the ventricles to be filled. So that can affect the preload. The other thing that can affect the preload is the venous return, and hence if your patient is hypovolemic, then he will have less volume to come back to the heart, and then smaller volume to come out of the left ventricle. Another important point is the ventricular compliance. If there's stiffness in the ventricle for any reason, then that also might impede the filling of the heart. For the afterload, we can think of the arterial vascular resistance again, and we know this also can be impacted by the sympathetic nervous system. Another factor that might affect the venous return, obviously, is the intrathoracic pressure change, and we will talk about this later on when we talk about the heart-lung interaction. Now, moving on to the arterial waveform, again, we can get so much information by just looking at the arterial waveform, and with the utilization of advanced devices, nowadays we can even calculate or estimate the cardiac output and the systemic vascular resistance. It's really important to remember the first part of the arterial waveform represent the systole, the ventricular ejection of blood, and the initial part here at the top, the start of relaxation of the ventricle until you reach to the diacritic notch, which represent the closure of the aortic valve. Then this part of the waveform, the runoff, if you like, wave, represents the systemic vascular resistance, and here you get to the diastolic blood pressure. It's really important to remember that systolic blood pressure reflects usually the stroke volume, whilst the diastolic blood pressure reflects the systemic vascular resistance. And take it as a principle, if you like, in your practice. Whenever you see a patient with diastolic blood pressure of 40 millimercury or less, then most certainly you are dealing with a patient with reduced vascular tone, reduced systemic vascular resistance. You might have other issues with the patient, but at least you need to keep in mind that probably a major factor in this patient's hypotension is reduced systemic vascular resistance. Now, this is an interesting study correlating the arterial blood pressure with organ blood flow, and we can see here for a given arterial pressure, the blood flow to organs is variable. So for the same for the same pressure, we will see that the blood flow to the kidneys is quite high. The liver, which requires, or it seems that the same blood pressure will achieve adequate organ blood flow at lower level. Why is this important? It's really important because when you drop the arterial pressure by only a few millimercuries, then you will see there is a huge drop in the kidneys organ blood perfusion, in the kidneys blood perfusion, compared to the drop in the gut blood perfusion, and the least would be the liver blood flow reduction. And that would explain to us why the liver is so resistant to developing shock during a hypotension situation. We'll see that the kidney is very sensitive, and it's the first organ to be affected with the hypotensive situation, whilst the liver requires really severe blood pressure drop to achieve or to cause shocked liver or ischemic liver. Obviously, part of this to do with the dual liver blood supply, but at least that's what we can see also in this experiment. Right. Oh, this is replicating itself. Now we'll move on to another important principle in the physiology or hemodynamic physiology, which is the blood pressure autoregulation. We know that autoregulation is present in all vital organs, mainly the brain, the kidneys, and the heart, and this is to ensure stable perfusion even with blood pressure fluctuation. Unfortunately, in a critically ill patients, this process is quite disturbed, and the patient becomes dependent, or the flow to these organs becomes dependent on the blood pressure, and that's why we try to make sure that we keep the blood pressure at adequate level, because we have no other mean of assessing the flow, because the autoregulation process has been significantly disturbed. And what do we mean by the autoregulation? It's really simply stating that the blood flow will remain stable over a wide range of pressures. And if there's a drop if there's a decrease in the pressure, then the resistance will increase in the blood vessel to ensure the maintenance of the blood flow, and vice versa. If there's increase in the blood pressure, then the vessels will constrict to maintain the flow adequately within the adequate target to achieve the organ blood flow. And this can be illustrated in this diagram. So initially you will have a drop in the blood pressure. This will lead to drop in the flow, and with a slight initial change in the blood vessel resistance. However, when the autoregulation mechanism kicks in, then you will have a drop in the resistance, and this drop in the resistance will restore the blood flow to the organ. Another important concept to remember is the correlation or the relationship between the mean arterial pressure and the cardiac output in relation to the systemic vascular resistance. So for a given map or mean arterial pressure, then you will have cardiac output. This cardiac output will drop down if there is increase in the systemic vascular resistance, whilst the cardiac output will go up if there's a drop in the systemic vascular resistance, as we see commonly in distributive shock states. Now we'll talk about the ventricular-arterial coupling, and here we have a few situations where we correlate the map with the cardiac output. First of all, in situations where we have low map with high cardiac output, can anyone tell me in which situation we get that? You'll have low mean arterial pressure and high cardiac output. We just mentioned that. Yes, I didn't hear that. Septic shock. So that's what we see in vasodilatation or distributive shock, or whenever you are using vasodilators, so you'll end up with low map and high cardiac output. Okay, so now if we have a situation with low map and low cardiac output, can somebody give me a scenario that correlates to this? So you have low mean
dehydration, absolute dehydration,
and low cardiac output. Well done. So in hypovolemia, indeed. Thank you very much. So here you have low venous return, hypovolemia, and you can see this also in acute heart failure, so before the congestion of the circulation, or you can see it as well in tamponade. The next one is the high mean arterial pressure associated with high cardiac output. Any takers?
pregnancy, thyrotoxicosis.
Okay, so you're saying there's high mean arterial pressure with high cardiac output. That's what we call the normal state, if you like, or the state of normal ventricular arterial coupling. When you use inotropy, for example, then you will get high MAP and high cardiac output. Also, if you give fluid resuscitation and the patient is responsive, then you'll get this situation as well. Thank you. And then we have the situation, the last situation is the high MAP and low cardiac output. Any takers? So we have a patient with low cardiac output and high MAP. So this is what happened when maybe we overuse the vasopressors, or because or the patient has got vasoconstriction for any reason, for example, sometimes associated with pain. But here you can get the low cardiac output and high MAP. As I said, we will talk more about shock states tomorrow, inshallah ta'ala, where we can even try to ascertain how to differentiate between different types of shocks. A few words about target mean arterial pressure. It's commonly stated in literature that 65 millimercury is the ideal mean arterial pressure in ICU, except certain situations where there's consensus that probably higher MAP is required, usually above 80 millimercury. Examples of that is the high ICP, subarachnoid hemorrhage, especially after obviously securing the aneurysm to prevent delayed ischemia. But is this a blanket decision or one size fits all correct in medicine? I'm sure you will agree with me, this is not true. We know that some patients would benefit from having higher MAP, especially those who are used to chronic high blood pressure. And when they come to ICU, even targeting 65 millimercury of MAP, would it be adequate for them to maintain good organ function? And on the other hand, we've seen it probably all of us when we are dealing with chronic kidney disease patients or chronic liver disease patients. These patients usually are running on lower MAP all the time and doing their daily activities without any issues with a MAP of 55 or 60. So when they come to ICU, for you to target a MAP of 65 and keep them on pressors doesn't really make sense, because these patients usually are quite healthy on MAP of 55. A few days ago, I can share this story with you. I got a patient with foot ulcer, chronic kidney disease on dialysis, and he stated to me clearly, look, usually my blood pressure is very low. I run around 80 systolic blood pressure. And the referring team were insisting that this patient must have ICU admission to initiate vasopressors. And they initiated it in ER. As soon as he came to ICU, we took the detailed history from him. We went in within 2 days, he was completely off pressors, because we accepted that a MAP of 50 for him was quite good for him. Mentally, he was quite good with it. And that was the most important thing, because obviously he lost his kidneys. So really, the target MAP should always be individualized for your patients, rather than the concept of one size fitting all patients. Now, we need to remember that mean arterial pressure doesn't equate to perfusion pressure, because perfusion pressure is the input pressure minus the output pressure. And we can have this famous example of cerebral perfusion pressure. We know to maintain adequate CPP, we need sometimes to have higher MAP if there's high intracranial pressure, because the CPP equals the MAP minus ICP, provided the ICP obviously higher than the CVP. And when you are dealing with the conditions of, for example, abdominal compartment syndrome, then again, abdominal perfusion pressure will be the MAP minus the intra-abdominal pressure, when the intra-abdominal pressure is higher than the CVP. And this all being established in this nice article by Cato and Pinsky. And here they also mentioned the heart with the diastolic blood pressure being the inflow pressure for the coronaries. And here the perfusion pressure for the coronaries would be the difference between the diastolic blood pressure and the CVP or the intrathoracic pressure, whichever is the higher reading. So keep this in mind. MAP doesn't always equal or doesn't usually equal the perfusion pressure, and you need to keep in mind the outlet pressure, because that's what dictates whether the organ is being well perfused or not. Now, moving on to one of the major parts of this presentation today, which is the heart-lung interaction. We will learn the concepts of heart-lung interaction with the differences between the spontaneous and mechanical breaths, the transvascular pressures and its importance, and also the transmural pressure and how we can deploy the concept of transmural pressure in heart-lung interaction to benefit the heart. Then we can mention the few clinical utilization of heart-lung interaction to assess the hemodynamics. Now, this is the schematic diagram of the spontaneous breathing, and here we can see that in inspiration we generate negative pressure, and this will lead, when we are talking about the hemodynamics, this negative intrathoracic pressure will lead to higher gradient of the blood to run through the inferior vena cava, and that's why the inferior vena cava ends up collapsing. And then during expiration, the reverse will happen. There will be higher intrathoracic pressure, and that leads to impediment of the venous return through the IVC, and hence the IVC or the inferior vena cava will get engorged. And this is what we usually see when we apply the ultrasound transducer to assess for IVC diameter and IVC variability. On the other hand, we know with the positive pressure ventilation that the intrathoracic pressure is quite high during inspiration, and this will lead to impediment to the venous return through the IVC, and that IVC will get engorged and expanded. And then during expiration, there's drop in the intrathoracic pressure, which allows the blood to rush back to the heart, leading to the collapse in the IVC. And we can see this as cyclical change during the respiratory cycle. And that's how it looks on the ultrasound when you apply the IVC, the ultrasound to the abdomen to check for the IVC. Now, another important principle related to the heart-lung interaction is that the hemodynamic effect of large lung volumes on the heart is mainly mechanical. And nothing better to illustrate this principle than this study in which they took the CT scan of the chest and mechanical ventilation during 0 PEEP. And here you can see during expiration and inspiration. And we can see during inspiration, the heart seems a little bit smaller than the heart during expiration. But to illustrate this further, if we apply PEEP of 10, then you can see how significantly the heart is compressed within the cardiac fossa due to higher intrathoracic PEEP. So imagine this intrathoracic pressure compressing the heart, compressing all the cavities of the heart, and this obviously will no doubt impact on the cardiac function, and hence the hemodynamics. Also, it's been long established that during inspiration, there's cyclic changes in the arterial pulse waveform. And here we can see this if you superimpose the arterial pressure waveform over the ventilator waveform, and we can see there is this cyclical swing, or we call it sometimes arterial swing, in the arterial pressure waveform. And if you apply expiratory hold, as you can see here, then this variation is totally or completely lost. So this is very important concept, and this is further illustrated by this study in which they increased gradually the intrathoracic or the airway pressure, and that led obviously to change in the tidal volume, and this led to higher the pressures inside the chest, the higher the change in the or the swing in the blood pressure waveform. Again, this just to illustrate that cyclical change in thoracic pressure or intrathoracic pressure between inspiration and expiration will lead to swing in the blood flow, leading to swing in the cardiac output, and this will be reflected in the blood pressure waveform. Any questions so far, or are we good to crack on? It's been 40 minutes already. Are you still with me, guys?
Yes.
Right. Yeah, thank you very much. At least I know somebody is paying attention. Great. Right. So we need also another principle about heart-lung interaction to keep in mind that spontaneous ventilation is an exercise. And this is really crucial to consider whenever we are weaning patients from mechanical ventilation. Anyone who is suffering with heart failure, or we call them at risk of heart failure, then really we should optimize their hemodynamics before we extubate them to avoid them going into flash pulmonary edema and the need for re-intubation. One thing to remember, that spontaneous inspiration will decrease the intrathoracic pressure. As we said, this will lead to increased venous return, and this will lead to increased intrathoracic blood volume. So in the next heartbeat, this will lead to, with the alveolar dilatation, will coincide with engorged veins, and this will optimize the gas exchange. So simply during spontaneous breathing that we created on, then the inflation of the alveoli is coincided with a lower intrathoracic pressure. So there is a gush of blood into the thorax, and that means all the vessels are engorged and ready to have the gas exchange from the distended alveoli. Whilst in positive pressure ventilation, yes, there's distension in the alveoli. However, this unfortunately caused the intrathoracic blood volume to be reduced, and that affect to some extent the gas exchange. We know from animal studies that a PEEP above 15 significantly compromised the hemodynamics of animals under the study, and the idea comes from the fact that high intrathoracic pressure will affect significantly the hemodynamics. The effect of respiratory cycle on the cardiac volume and pressure will illustrated in a few slides, and we'll talk about the blood flow into the heart from the IVC, and then we will talk about the lung hyperinflation causes in relation to perialveolar vessel compression and the increase in the pulmonary vascular resistance or the acute pulmonary. Right. So this is again schematic illustration of the alveoli, and here we have the alveolar septal capillaries, and these are the extra alveolar vessels. So this is in the normal situation. You can see they are all looking nice and ready for gas exchange. However, when there is distension or overinflation of the alveoli, then this will distend all these alveolar septal capillaries and reduce their efficiency in gas exchange, as well as this will impact on the extra alveolar vessels. And this is further illustrated in this study where they found that either sides of the lung volumes can be detrimental to the pulmonary vascular resistance. So if you ventilate your patient at higher level of tidal volumes, close to the total lung capacity, then this will increase the pulmonary vascular resistance. And this can be illustrated schematically here by distending the alveoli. This will compress the intra-alveolar vessels and cause increase in the pulmonary vascular resistance. And on the other side, if you ventilate your patient close to the residual volume, this will lead to collapse and atelectasis in the lung, and that will lead to increase in the pulmonary vascular resistance. And really the ideal or the sweetest spot would be to ventilate your patient around the functional residual capacity. Now, the concept of transvascular pressure is another important concept. We know that the higher transvascular pressure, the higher the venous filtration pressure, and that usually associate with pulmonary edema. Transvascular pressure is really the product of the difference between the vascular pressure and the pleural pressure. And this is, if you like, just an example to illustrate the case. So for same transpulmonary pressure, we can see here that the transvascular pressure is different from this patient to this patient to this patient. And this patient would really have higher chance of having pulmonary edema. And those of you who worked with the COVID patients, especially in the early stages of COVID, we saw a lot of patients having a high respiratory drive, and this high respiratory drive was associated with a huge swing in the intrathoracic pressure. So the transvascular pressure for these patients would have been very high. That's why we ended up giving these patients, even though they were awake, a lot of opioids just to try to dampen their respiratory drive. And some of them we ended up intubating them just to protect them from what we later, what's been known to be self-inflicted lung injury or SILI. Right. Now we know that spontaneous inspiratory pressure, spontaneous inspiration decreases the intrathoracic pressure, and on the other hand, positive pressure ventilation increases intrathoracic pressure. So the positive pressure ventilation decreases the left ventricular afterload by reducing the left ventricular transmural pressure, and this can be illustrated in this scheme here. So imagine the heart is a compartment inside a compartment, or a box inside a box, and inside the circle here is the representation of the left ventricular pressure, whilst the green area represents the intrathoracic pressure. So if we have the left ventricular pressure of 100 millimercury and the intrathoracic pressure of -20, then the left ventricle has to overcome 120 millimercury of pressure to eject the blood outside, because there is the negative intrathoracic pressure pulling the heart away, preventing it, feel like, from collapsing and ejecting the blood outside. On the other hand, if the same patient, you put them on the positive pressure ventilation, then this positive pressure ventilation will augment the function of the heart, and you can see that the transmural pressure will be 80 compared to 120 in the first example. And here you can see that the positive pressure ventilation is augmenting the function of the LV. And that's why in heart failure patients, it's advised to apply positive pressure ventilation, whether it's done invasively or invasively if you had to. Sorry. Right. Now, one of the best illustrators of heart-lung interaction is Pulsus paradoxicus. Any questions so far, by the way, or we're nearly done, I think, maybe a couple of slides more, and then inshallah we'll allow time for the questions after the session, after the first session. So, as I said, the best way to explain the heart-lung interaction is really Pulsus paradoxicus. We know that Pulsus paradoxicus is a more than 10 millimercury difference in systolic blood pressure between inspiration and expiration, which is, as we know, it's lower in the inspiration. And here we can see this same illustration that during inspiration, there's a drop in the systolic blood pressure. And examples of that, obviously, the status asthmaticus and cardiac tamponade. The status asthmaticus also gives insight into the biventricular interdependence. In the normal circumstances, usually the RV is semilunar and the RV is more in Gore's semicircular shape. However, if there's a situation where there's large venous return to the heart, or there's no space for the RV to expand, then this will push the septum leftward, and that will impede the filling of the left ventricle, leading to drop in the cardiac output and hence the blood pressure. Now, we can use the heart-lung interaction to assess fluid responsiveness during mechanical ventilation. And this is one of the illustrations of how we use pulse pressure variation in relation to ventilation to decide whether our patient is fluid responder or not. I'm not going to dwell into this now because we have a dedicated session for the advanced hemodynamic assessment, inshallah. These are the, if you like, the clinical utilization of heart-lung interaction. We can measure the systolic pressure variation. It's not commonly used nowadays. The focus has shifted a lot towards the pulse pressure variation and stroke volume variation. And we have more devices in the market nowadays to use these concepts to assess the volume status of the patient. Another important concept is really the end expiratory occlusion test. So the same thing, during you do expiratory hold, and this would allow more venous return to the heart. And if your patient is fluid responder, then they will be increased in the cardiac output after you apply expiratory hold for 15 seconds. And if that happens, then if you give volume loading to your patient, there's high chance they will respond to fluids if the expiratory hold has caused 5% increase in the cardiac output. Again, I'll talk about this in more depth during our fluid responsiveness session. Another utilization of the heart and lung interaction is really assessing the IVC variation during inspiration and expiration, whether in mechanically ventilated patient, which is more accurate, or even in spontaneously breathing patients. We'll talk about this in more details later on, inshallah. A few words about the glycocalyx. Glycocalyx is a web of membrane-bound glycoproteins and proteoglycans on the inner surface of the endothelium. And when this membrane breaks down, then it leads to leaky capillaries and third spacing. So you need to be mindful of this situation. This is the electronic microscope illustration of the glycocalyx, and here we can see it like a moss, and this is magnified to 1 micron, and you can see it like a fluffy structure on the inner side of the blood vessel. And what happened if the patient exposed to toxemia, endotoxemia rather, then you can see there's break in this inner layer, and this with higher magnifying capacity. This obviously will lead, as we said, to capillary leak. Situations where the glycocalyx get dysfunction are SIRS, systemic inflammatory response syndrome states, like sepsis, trauma, surgery, diabetes, hyperglycemia. All these situations can affect the glycocalyx integrity and lead to seepage of fluids into the interstitium, and you end up having an edematous patient. However, the intravascular compartment is quite depleted. As we said, no one can talk about hemodynamics without talking about thick equation, about the correlation between the oxygen consumption and its determinants, which are the cardiac output and the oxygen content difference between the venous and the arterial side. As I said, we'll talk about this later on, inshallah ta'ala, in the perfusion indicators session. So to conclude this session, inspiration in spontaneous breathing lead to negative pressure inside the thorax, leading to increased venous return to the heart. During positive pressure ventilation, high inspiratory pressure reduces the venous return. The principle is utilized for many tests used for assessment of fluid responsiveness. For example, the stroke volume variation, pulse pressure variation, IVC variation, and obviously even CVP variation can be used. Spontaneous breathing represents a strenuous exercise to the weak heart. So please pay attention whenever you are weaning somebody from positive pressure ventilation to negative pressure ventilation. High ITP or intrathoracic pressure enhances the left ventricular function and vice versa. With this, I'll conclude this session and take any questions before we move to the next session, the hemodynamic jigsaw puzzle. The floor is yours, guys, if anyone would like to ask.